It would be funny if it weren't so scary.
Yeah, exactly.
Right?
Exactly.
It's amazing. But we welcome everyone. My name is Ray Kober. I am your host. Welcome to Let's Go. This is our maiden voyage, if you will, a podcast. I'm joined by Scott Fuqua of AMPS, and we'll jump into it in a minute. But uh, again, Adam ruins everything. We thought that would be a good place to open this up because it makes a parody out of something that is so, it does make people anxious. I think she said it best. It's just it's on everyone's mind all the time, and costs are out of control, and most employers have no clue about how to manage the expense and what the steps are that they should take to lower costs. But before we jump into it, I'd like to share a little with the audience about how I got here,
Oh,
and
just
then
yeah, and just one thing real quick. Hey, we got a bunch of people on the call today, guys. So everyone is is muted, but we want to hear from you. You're going to have
100%.
some questions. There should be a chat button somewhere on your screen, wherever it is on your particular screen. But please use that chat button. Any questions that you have throughout the thing, just punch them in there. And towards the end, we'll save a little bit of time and address those questions. We love questions, so please post them as you can. Sorry about that, Ray. I just want to make sure everybody knew.
No, thank you for that. 100%. We want to hear from you, and we'll get to as many questions as we can at the end of this. So, no one grows up saying they want to be in insurance, right? I was no different. And I was introduced to the opportunity by some friends of mine, and they were having success and enjoying a good lifestyle. And the other thing that really appealed to me is, done well, you have the ability to help others. So I'm a capitalist through and through. Love Ken Langone's book, I Love Capitalism, the architect of Home Depot, famous philanthropist, forgave the medical debt of NYU medical students. Amazing guy. I love money. I'm not making any bones about that. But I also want to help others. And there are a lot of ways to make a buck in this world. Part of the issue that I have with healthcare is we have publicly traded insurance carriers with the fiduciary obligation to shareholders, not policyholders. And so there's a huge conflict of interest there. And we're going to talk today about their approach to business. Their sales force is an army of publicly traded brokers or large privately held brokers, and their interests are aligned, but they're not aligned with their clients' interests. And the majority of folks in this country get their healthcare through their employers. So you are the conduit to healthcare. And done well, you can not only lower costs, but you can also improve the quality of care. And we're going to dive into some of that. Some of the key takeaways today are going to be your ability to understand what you can do about healthcare in terms of understanding your fiduciary responsibility, understanding what drives costs up, what's baked into the Affordable Care Act that drives costs higher. And even if you're a self-funded plan, how being on that chassis drives costs higher. We want to share with you how to calculate what is the math behind healthcare. What's the starting point? Can you control something that you can't measure? And the obvious answer to that is no, you can't control an expense that can't be measured. So we're going to talk to you about PEPY and what that crazy ton of acronyms in healthcare, Scott. So, right, per employee per year cost. What is that? How can you calculate that? Why is it important to know if you're a CFO, a CEO, a CHRO, someone in human resources, anyone that's tasked with managing healthcare as an expense? PEPY is a starting point, and we're going to talk to you a little bit about that. We're also going to share some bolt-on strategies or solutions. We're going to give you ways to help you understand that your data can uncover the key, unlock the key to success in healthcare. It's not what we're discussing today. And by the way, whether you engage our services here at Benefixa or Scott services at AMPS, and we're the conduit to that, or you go out and leave this webinar thinking, hey, I didn't like those guys, but a lot of what they said made sense. We encourage you to take an active role and to inspect what you expect, right? It's not enough that you just rely on your broker's advice to manage this top expense. It's typically a top expense after payroll. So I'm in this game because I root for the underdog. I love saving employers money. I've been doing that through my entire career. But what's more important to me is to actually save policyholders money, your team members, your friends, your colleagues. I call them, my second family are the people that I work with.
Yeah.
So those are the folks that we care about most, and you can actually reduce the cost of healthcare and increase the quality. That's a little bit of, why I'm in the game, Scott. I'd love to hear from you. How'd you get involved in this crazy game? And if you could tell us a little bit about AMPS, because I'm sure that's the question mark for some folks.
Yeah. Well, thanks. Right. Yeah. And just like you, you didn't go to college to be in the insurance game. I actually went to college from a marketing degree, got a really nice job in London, and that was great for a couple of years. It was a small company, ended up getting bought out, one of those types of things. So when I came back to the States, I got a job through a friend of mine at a company called Healthcare Compare. And that's what started my healthcare career. I also was doing a little bit of work comp and some others, but over the last probably 23 years, it's really been focused on helping self-funded employers get control over this cost, right? And peeking under the hood of healthcare. What it is that drives me. I had that question about a year ago. Somebody said, boy, you're really passionate. What is it about this that you love about healthcare? And it's like, well, again, I don't know about loving healthcare, but what I don't like is bullies. I don't like shell games. I don't like con men. I don't like that kind of thing, right? Never have, even as a little kid. And I think that's what drives me, because unfortunately, I think that's what this industry is a lot. When you peek under the hood, there's misaligned incentives, things going on that people have no idea, which leads to the $1 million question that everybody has. Why are these costs going up every year? Why do I not understand why? And why can't I get the answer from even my trusted advisor or the TPA that I work with, or the carrier that I work with? So that's kind of a little bit about me and why I'm here and why I am passionate about it and want to continue to help people. But also in terms of AMPS has been a company, we've been around for about 19 years. I'm sure people on the phone are like, who is AMPS? You've been around for 19 years and I've never even heard of you. Well, it's because mainly we work through the broker community. We don't go directly to employers. We work with trusted advisors, which can be a challenge sometimes, as we'll talk about in a little bit. But we focus on employers and employees and getting control of health plans, to Ray's point earlier, of giving you a health plan that is going to save you money, is going to give you a flat trajectory instead of an increased trajectory every year, but without removing benefits, right? That's the key component of what we're talking about today. So AMPS does all kinds of things that can help on the medical side, as well as the pharmacy side, which is a growing animal for everybody. We're seeing pharmacy spend meet, if not exceed, medical spend in some instances. That's the first in the 25 years I've been doing this. And none of those claims costs are going down. They're all consistently going up. So the things we're going to talk about today can help employers on both sides. But there are some caveats to it in terms of how we can fit in and what type of employer. But other than that, that's a quick nutshell on AMPS, and hopefully we'll get an opportunity with the folks on the call today to have some more in-depth conversations post this discussion today.
Thank you for that. So I guess the starting point, just to define the players in this game, and by the way, it's never our intention to ram any particular strategy down the throat of an employer or an organization. Ultimately, we understand that culture eats strategy for breakfast, right? We get it. That's a famous Drucker quote. It starts there, and I think all of our strategies start with, what are the organizational objectives? Where do you want to go? Where do you see yourself 3, 5, 10 years from now? And how could we help you get there? If we're not starting with kind of the end game in mind and skating to where the puck is going to be, we're not going to be effective.
Agreed.
So at the end of the day, I think you have to understand that if you do nothing and if you remain status quo, and I don't care if you're in a fully insured strategy right now with a major insurance carrier, or you're in a self-funded strategy with an insurance carrier as the administrative services organization, you're running on the same chassis. And I could tell you where you're gonna be and where you're gonna go.
Yep.
And Scott's laughing because he knows where I'm going with this. In 8 years, your costs are going to double. They're going to 2x. Can your organization afford that? And how are you going to manage that? Are you going to cost shift to employees as we've done so wonderfully with HSAs and high deductible plans? Are you going to shoulder that cost? And if so, where is the money going to come from? What we propose is something quite different. Think about if you can, if what we're sharing with you today is true, and if you're feeling it, if it's resonating with you, if you can improve the quality of healthcare and lower costs, what would that mean for the organization? So I'd like to talk to you a little bit about that. And I think the starting point, really don't want this, I want this to be a conversation. And when I first talked to you, Scott, about this, I said, I really want us to have a conversation and have them be a fly on the wall. Like we're hanging out somewhere, enjoying the beverage of our choice, and we're just commiserating about what's going on in healthcare because we're both in the same space. And we often answer, we complete each other's sentences.
Yeah.
So
Totally.
it's just about sharing with folks that, hey, you can do this. You can, this is a manageable problem and it's fixable, but you have to have the resolve to fix it.
We have 2.5 million lives across the country doing the things that Ray and I are talking about today. And last year, or a couple of years ago, in the middle of COVID, I actually had a case in Indianapolis. Give me a call. The CFO said, "Thank God for you guys. I don't know where we would be right now in the middle of this mess if we hadn't have squashed these costs the way that we have through your organization." So, those are the types of things, like we go back to what we talked about before. That's what makes us feel good, right? That's what we're doing this for.
100%. And so we're all used to the dog and pony show of the broker who often, and I get it, it's going to sound, you're going to hear a lot of stuff coming out of my mouth, Scott's mouth, that may not be the most complimentary, shall we say, when it comes to insurance carriers and brokers. And brokers in particular, there's a Marshberry study that was conducted, and I was part of a seminar. Your broker could do a terrible job, meaning that they will bring back increases year after year. Because if you think about it, you're relying on a broker for advice. You want to go to them and say, hey, come to us with solutions. Come to us with ways that you can improve the benefits that we offer our employees and ideally reduce costs. And year after year, not due to any fault of theirs in particular, costs continue to increase and the quality of care goes down, meaning more out-of-pocket costs for your employees, your team members, higher costs for your organization. So essentially, they're failing at their job, and they could do a terrible job. And the average tenure of a broker, according to Marshberry, an analytical consulting firm, is 6 years. So imagine that. You could do a terrible job and still not get fired. And the number one sticking point for us as consultants is to really get people over the hump of saying, hey, I'm fed up with this. I can't have this anymore. I need someone to think outside of the box and come up with solutions and not grasping at straws or, conjuring things out of thin air. But your broker should be bringing you legit strategies that are proven with math and examples. And we certainly have that. But what you need to understand is it's not in the brokers. And while your local rep, maybe your friend, maybe your buddy, you go out to games together, you go to the theater, wonderful lunches, dinners, et cetera, et cetera. When you're charged with a fiduciary responsibility of managing plan assets on behalf of your organization and your members, you owe it to your organization and you owe it to your second family, your coworkers, your team members, to at least take a look under the hood and inspect what's going on. And I know that, Scott, you have a few words to say about fiduciary obligation and where we're going with that.
Yeah, I mean, it's a trust but verify, right? It's a term that everybody knows, unfortunately isn't necessarily utilized so much in this space, right? Going back to some of the comments about brokers and how they're compensated, I run into many times employers that have a advisor broker situation where they're tied to premiums. The more I spend as an employer, the more they make. It's one of hundreds of misaligned incentives out there that are getting in the way of people's fiduciary responsibility, obligation, and liability. I mean, when you're talking about things like, the CAA and, Department of Labor and things that are going on out there, this was a big deal. Fiduciary responsibility has always been a big deal in the welfare space, right? 401ks and things of that nature. But over the last 3, 4, 5 years, it has become really a hot topic on the health side. Why? Because there's way more money being spent there. There's way more money from a member's perspective that's getting involved. But to the point you were making earlier on, if I don't have insight into this second largest expense next to payroll, which is what it is for most people, how am I meeting this fiduciary responsibility that's being dumped on me? There's been a lot of lawsuits and cases and things over the last few years where it's made it very clear the buck stops with the self-funded ERISA employer. It is their responsibility to protect plan assets when it comes to the health plan. It's that simple. So I think for many years, healthcare has been looked at one time a year, sort of a sprint instead of a marathon, like you were saying before. And because you don't have any insight, you're looking towards an advisor to chase the lowest increase that you can get for that year, get that in place, get new IDs cards out to everybody, and go back to work. You got to manage this throughout the year, but you got to get into a situation where you have full transparency and where you're working with the status quos of PPOs and carriers and ASOs and things like that. You do get some data, but I'm going to tell you right now, you're getting about a half a picture, and that's by design. So you're in a corner. You've been painted into a corner in working in trying to manage an expense in an industry unlike anywhere else in the world. Nothing works like healthcare in the United States except for healthcare in the United States. But again, when you peek under the hood, unfortunately, it's very ugly in terms of it's not a broken system. It's designed exactly the way the major shareholders of this industry want it to be, which has
100%.
resulted in your 8% increase throughout the years. You have a 30-year model of PPOs and these general structured models of a complete failure, yet 95% of this country goes back to that solution every single year.
100%. We got a great comment from one of our attendees, a vet, saying insurer first proposes 35% increase. Broker tells you we negotiated them down to 20%. Isn't that great? And we've all been there, right? We have
hamster
clients
wheel
every year, and they go back. And so look, again, I don't want this to be slide heavy, but I think this is a nice segue for why that happens.
Yeah.
And so here are 7 health insurance CEOs who made $335 million in 2022. And the source of this is Wendell Potter. He's got a newsletter called Now Newsletter. He's a former Cigna exec turned whistleblower. So he's an insider, someone that was on the corporate jets, in the boardroom, in the meetings, talking about strategies to grow the business as an insurance carrier. It's a wonderful newsletter. I'd encourage you to subscribe to it. It really will give you some insight as to what's going on out there. But when you have CEOs making this kind of money, and again, I am a capitalist through and through. I have nothing against people making money and organizations making money. I think it really is it's one of the key drivers of America. I think it's important to say that for the record. The trouble with this, though, is this is an egregious amount of money, and it's on the backs of the policyholders, because that conversation, when your insurance broker walks in, of costs going up and, hey, here's a 35% increase, and then they negotiate it down to 20%. Let's call it what it is. That's bullshit, right? That is complete BS. And if you look at, the stock ticker, and this is from the onlineinvestor.com, anyone could go here, you could plug in the ticker symbol of a company, and you could track the historical performance of an investment in that stock. So if we go back to January of 2010, when the Affordable Care Act was first introduced, the share price for United Healthcare was trading at $31.53. If we track that to today, it's now trading at $482.56. If you reinvested those dividends, a $10,000 investment would get you to $187,000. That's over the course of, the past 13 years, not even. So I want you to think about that. We invest in typically our homes and in a bunch of other things, but let's use a house as an example. The average house in the country, I don't know, is probably somewhere around $200,000 to $300,000. In the New York metro area where I'm coming from, it's significantly more than that. But let's say you took $100,000 and you put it in United Healthcare as opposed to investing in your house. You'd be sitting on a pile of money today that eclipses what your house appreciated in value at. And your home is typically one of your quote unquote best investments. In the meantime, your costs have gone up significantly. So the cost for healthcare, and this is Kaiser Family Foundation, this is again public information, it's out there, but you're spending $2,000 to $7,000 in 2001. Today you're spending $8,000 to $23,000 for the same exact coverage. Milliman says we're going to spend $31,000 in 2023. It's going to be the average premium for a family. And if you're in a major metro like the New York City area, where I'm in, or you're in the Chicago area, Scott, essentially you're probably looking at $40,000, $50,000 plus. It's insane. And so I'm going to pause there with the slideshow, but the point is, these entities are not your friends. Everyone falls in love with a little logo on their insurance ID card, health insurance ID card. But the reality is United Healthcare, Cigna, Aetna, CVS, Humana, et cetera, the VUCAs, as we call them, they are not responsible for administering one iota of healthcare. They are insurance companies. And so you have the ability to manage the supply chain of healthcare and procure healthcare without their help. And why would you want their help when all of their efforts are aimed at driving value for their shareholders? They don't care about their policyholders. You're not their clients. What do you think, Scott?
Yeah, I couldn't agree more. In fact, everybody on the phone, if you're working with any of what Ray and I would call the BUCAs, which is Blues, United, Cigna, Aetna. Well, Humana just bailed out of the employee benefits world. But ask them, would they be a co-fiduciary to your plan? I guarantee you I know what the answer to that is. It's absolutely not. They will not put their money where their mouth is. It is misaligned incentives. There's a case going on in Massachusetts right now with the union that's gone after, I think, Anthem, saying, listen, you're not allowing me to meet my fiduciary responsibility. You won't share all the data with me. The response was, you're right, I'm not a fiduciary, and I'm not going to share all that data with you. Because you know what? That's proprietary. It could affect my margins, could affect my shareholders, right? So finally, it's been documented and come straight out of one of these major players' mouths of what you and Ray and I have known forever. They're not in it for anybody but themselves. And what's also interesting is I could put a slide up there to show you the CEOs of the biggest hospital systems in this country. And they're making as much, if not more, of those people. How many patients do they touch? Zero. UPMC in Pennsylvania, in Pittsburgh, 31 executives. The payroll for those 31 executives is over $40 million. The CEO makes 12 million plus bonus.
Insane.
During the same time, when everybody is hurting immensely when it comes to these costs, over that same time period of when the Affordable Healthcare Act came in, who was at the table at the Affordable Healthcare Act trying to help design that? The BUCAs. And who, as you could tell from the stock prices, who benefited from that? It sure as heck isn't anybody that's on this call today.
Yeah, I got a great slide to that point. Let me just share this with you. So one of the big problems with the Affordable Care Act and something that got baked in was something called the MLR. So everybody, everybody's AI crazy these days. This is right off of Chat GPT. I did this morning. Who architected the MLR and the Affordable Care Act? And you can do that yourself. But at the end, it says the MLR provision was developed as part of the broader ACA legislation and was likely influenced by input from various stakeholders, including lawmakers, policy experts, healthcare professionals, and advocacy groups. It is a complex and multifaceted law with contributions from many individuals involved in the legislative process. So what I have to laugh because it's so goddamn funny. But guess who won that battle? It wasn't the advocacy groups. Let's just put it that way. So for those of you that aren't familiar with the MLR, this is a stroke of genius. So if you remember the Affordable Care Act and the talks going on back in 2009 and 10 when they were trying to put get this passed into law, they were going back and forth and back to the drawing board. I was telling Scott the other day, it was like a telephone book, and he said, "No, Ray, you're wrong. It was like if you had to print it out, it would be stacked from floor to ceiling, right, Scott?"
Yes.
It's just crazy. How much
it's
is
about 12 feet tall.
correct? And so one of the things that was baked in is something that on the surface, I think, makes sense commonsensically. If you listen to what the MLR is, it says that for every dollar an insurance carrier takes in, they are required to spend 80 to 85 cents of that dollar on healthcare. That sounds really good, right? Until you analyze the other 15 to 20 cents of that dollar. The insurance carriers get to keep that for administrative overhead costs and, wait for it, profit. So what has to happen for insurance carriers to show more returns to their shareholders? They have to spend more money. If they spend less money, their shareholders suffer. And so that is a really important takeaway from today's call. If you understand and you wrap your head around the fact that if you're with an insurance carrier, one of the BUCAs, as we affectionately call them, and you're thinking that your costs are going to go down, it's impossible for their costs to go down because they're going to bill more year over year because their fiduciary obligation is to their shareholders, not their policyholders. And once you understand that and you wrap your head around it as a C-suite executive, as an HR professional, as a benefits manager, as a controller, for you to continue doing business with them, I hate to say it, but you're neglecting your fiduciary responsibility. And I'm going to be more blunt. You're just stupid. Why would you continue to do that? If you understand that when you're with them, and look, I understand that many of you folks have no choice, or you think you have no choice. You're with an insurance carrier because your employees demand that they have the best health care. Let me tell you something. Having United, having the Blues does not promise you that you have the best health care ever. In fact, I would argue that it hurts more than it helps. And here's why. Folks procure health care, they're just doing it wrong. You don't ask your golf buddy where he had his knee replacement surgery, and that's your barometer for a good surgeon. You don't ask someone that you sip wine with on Wednesday nights, where they had shoulder surgery, or, what surgeon who's the best cardiac surgeon. You don't do a Google search to figure that stuff out. It has to be baked into your plan. And in healthcare, often the highest quality is also the lowest cost. And the reason and the key for that is frequency and volume. When you're set up to do knee replacements, and that's what you specialize in, it's your focus, and you go to a freestanding surgical center, you're going to get a great result, and the cost is going to be a fraction of what you would pay through a traditional carrier quote unquote discount. So we could talk all day on this, folks. In the interest of time, I want to drill into some of the things that you can do to help tilt the cards back in your favor And some of the services that we rely on AMPS with is the ability to dive in and have insight. And where I was going, just to finish my thought or complete the loop on why Blue Cross or United is not necessarily in your best interest. Well, to use a Forrest Gump quote, it's like a box of chocolates. You never know what you're going to get.
Bingo.
Right. So the good, the bad, and the ugly is all mixed in that network. And who's to say that you don't have team members, family members that are picking a surgeon or a facility based on the proximity to their home, convenience, as
And,
opposed to looking at quality metrics and scores. It's huge.
yeah, and there's no preferred in a PPO anymore. A PPO is a preferred provider network, but everybody's in the network. So
Yeah.
everybody's preferred, everybody's quality. You got to think through things like that too, right?
100%. So, Scott, tell us a little bit about what you do and how you help employers kind of whisk away some of the opacity. How do we deliver transparency to them, and where do you guys come in?
Yeah. Well, the best way to show the value, which you mentioned early on, is in data. So we do complementary analysis. A lot of times that's some of the first step, working with an advisor like you, Ray, or a consultant like you, Ray, and your clients. So we would recommend that, right? Because everything we're talking about today, in terms of averages on a medical spend, you're going to save anywhere from 20 to 40%. So, and that's your biggest component of your healthcare cost are your claims. And that's where the system breaks down. Going back to what we've talked about so far, there's no solution out there from a traditional perspective that is attacking the cost of claims, because it's not in their best interest to do that, whether it's pharmacy or medical. So we start with analysis. I've never done an analysis at AMPS in the many years I've been here that doesn't fall within a savings of 20 to 40% on your medical spend. So, but we could show that to you because it's going to be different for everybody. Same thing on the pharmacy side, 20 to as much as 50%.
And
But
Scott, so that,
yeah.
sorry to interrupt, but so that may sound fantastical, right?
Right.
So
Yeah, it sounds crazy.
Is it real, and how do
Totally.
you prove it? How can they rely on the fact that it's not, smoke and mirrors, that it's
Yeah.
legit?
Let's do a data analysis. So anybody that's interested, you can reach out to Ray. I've shared with Ray, he already knows, the type of data that we need to look at both sides of the house. I would call it your pharmacy and your medical, and show it to you and prove it to you right there. If we can get the detailed data that we need, the more detail means the more insight I can give back. It's garbage in, garbage out, like any other type of analysis, and we can help you get what we need, and we will show you. And again, I mentioned it early on just really quickly, but I got 2.5 million lives of self-funded employers and municipalities and school districts and unions across the country that are doing this, that are running a flat to maybe 1% trajectory year over year. How do we get there? We remove the situations that you're in right now that are driving these costs up, like a PPO. A PPO puts a discount off the billed charge. Going back to the video at the very beginning, if those of you that jumped on had a chance to see that, hospital systems, for example, have something they call the charge master. It is literally a made up number of all their charges for every service that they would do. In fact, Ray mentioned a good resource for you in Wendell Potter. Go back to something called The Bitter Pill from about 10 years ago, a Time magazine article where they dedicated the entire issue to that one article. And that gentleman interviewed CFOs from hospitals across the country. Where do you come up with your prices? All of them pretty much said the same thing. We have no idea.
Yeah, and this is one of your slides, Scott. It's 1,000 to 3,000% above actual costs.
Yeah,
right?
I've actually got a facility in Central Illinois for infusion therapy. Somebody comes there for infusion therapy, cancer drugs. They bill 15,000% of what Medicare would pay them for the exact.
15,000%. It's a small markup.
So unless you have a 99.9% PPO reduction, your discount is useless. We call it a fake discount, an illusionary discount. The discount's off what? The discount's off the types of things you guys are seeing on the screen right now. a
Right.
mucus recovery system. That's no
That's my
joke.
favorite.
Yeah, it's a box of Kleenex, and I'm gonna
$75.
$75. So I'm gonna put a very creative name on it, or the oral cleansing device for $1,000. If
Wow,
anybody has ever unfortunately been in a hospital overnight, you get a toothbrush. It's not even a whole toothbrush.
that's
And they're going to
crazy,
charge you
right?
$1,000. That was actually on the news several years ago, from an interview that somebody had with an executive from AMPS.
But
So,
Scott, that's
yeah,
a hospital grade toothbrush, though.
yeah, exactly. No, it's an oral cleansing device. Right. So
that is hilarious.
it's just it's so nonsensical and so illogical that, again, once you get a chance to peek under the hood, again, going back to where my passion is, that's absolutely ridiculous. So if you remove those layers, you remove those components that aren't helping you, they're hurting you, it allows you to do things like review claims. Unbelievably, if you're working with one of the major groups that we've been talking about, their PPOs, you are actually removing your right to look at claims when they come in to make sure they're billed accurately. And I'm talking about black and white stuff. You're billing me for things you never did. There's coding rules that need to, it's very complicated, but there's rules.
Well, in fact, you have an exciting new service where we can mine for gold from past claims. And this is fascinating to me. You have the ability to go back in time, look at claims that were paid, and essentially, if you find errors, recover that money for the client. Isn't that right?
That's true. That's true. And we can go back and find all of the overpayments, which could be over a myriad of reasons. And we're recovering anywhere from 3-4% to as much as 15% of what somebody has spent over the last 3 years on their medical spend. So it's very significant. But in the world today, there's something that's called auto adjudication. 98% of claims come from the provider to the administrator carrier. Nobody looks at them. They just check, is Ray eligible? Yes, he is. Is the provider in the PPO? Yes, they are. Put a 50% discount on it and cut a check to the provider quickly, because that's who their client really is the provider, and send it out the door. Nobody's looking at it. For over 19 years that AMPS has been in business, we have reviewed billions and billions and billions of dollars worth of medical claims. At the facility level, where the biggest problem is at, where the biggest costs are at, 91% of the time, there's errors on those claims that on average equate to about 10% of the billed charge. So you have a $200,000 medical inpatient stay from a hospital, which is a charge that is every day these days. We see $1 million claims all the time. Nobody is looking at those claims. We have, last year, I did a claim, a $972,000 premature baby claim. They're all $1 million now. Years ago, $1 million claim would just stop. Everybody couldn't believe it. They're every day now. $517,000 worth of that bill was black and white errors, should not have been on that claim. Insane. Without AMPS, they would have applied their 52% discount and paid it.
Yeah. No, it's really egregious. And it gets back to the fact that it's not only the insurance carriers and the broker sales force of the insurance carriers, it's the providers as well. There's a rumor going out. I don't think it's a rumor. I think it's a fact that there's a hospital in Texas somewhere that charges people for a pregnancy test, whether they're male or female. If you're admitted there, you get charged for a pregnancy test, and it's billed at over $1,000.
That kind of stuff happens every day. You would be blown away by the stuff we see. Oh yeah,
that is craziness.
Cessation type stuff done on a child. I mean, it's all over the map.
And so, I would equate that to blindly paying a credit card bill. When your credit card statement comes, you see thousands and thousands of dollars in bill charges. You're going to review it. You're going to make sure that those charges are yours, that they're legit. It's not happening in healthcare. In healthcare, especially if you're with an insurance carrier that is in the business of paying more claims, because remember, paying more claims equates to more shareholder profitability. They're blindly paying these bills. So that's an issue. So if you'd like our help with this, we can shine a light on what your spend is. It's going to require claims data. doing an analysis. We do that for our clients. Sometimes we actually charge for it, but for folks that are visiting us today or that are watching the replay, we will do a complimentary analysis and show you where the bodies are buried, if you will. Another thing that I wanted to get to today is the best arbitrage in healthcare is something called the GO Plan. And the GO Plan is a medical expense reimbursement plan. Now, this was baked into ERISA back in the mid-1970s, and the plan has been around for over 20 years now. And what it is it's simply a way to incentivize spouses who have access to healthcare through their employer to go on that plan. And if you think about it, that's fair for everyone and it makes complete sense. Right now, today, many organizations allow spouses and dependents on their plan. Well, dependents is part of the package, right? You can't stop dependents from participating if you offer healthcare coverage. But if you have a spouse that has access to coverage through their employer, you certainly don't have to cover the spouse. And if you look at it actuarially, so there's an actuarial science that goes into healthcare. 40 to 60% of your claims are incurred by dependents, including spouse and children. Also, 20% of your claims are consumed. 80% of your claims are consumed by 20% of your members, meaning that the majority of folks that you pay for healthcare for are not even utilizing care, or if they are utilizing care, it's minimal. 20% are driving 80% of claims. And your top 1%ers, your super utilizers, they're consuming 25 to as much as a third of your claims bucket. So if you had a way to incentivize those folks to get off of your plan and go to an alternative plan, that would be a win for the plan. It would be a win for the team. It's a win for the entire organization. But how do you do that, and how do you make it a win for them? Well, it's simple. You incentivize them by saying, if you now go to your employer's plan, spouse, we're going to cover all of your out-of-pocket expenses, aka free healthcare. And when that happens, the magic really begins, because now your employee, your team member, is going to say, hey, I want to do that too. I want free healthcare. Your team member can then move with the spouse. So this is a phenomenal plan. I'm going to throw up a couple of slides, and we make this really easy for you to engage. If you go to thegoplan.com on our site, all that you need, if you're a C-suite professional, HR professional, you need two numbers. You need what your total all-in spend is on healthcare and how many employees participate. And if you input those two things, we're going to give you an instant result. And what we're showing you here, this is an example based on 1,000 employees participating at $20,000 per employee per year. And so the expected annual savings is $760,000 in that scenario. Over a 5-year period, if an organization is trading at, let's say 10x, their PE ratio is 10 times revenue, then the numbers that we would save the organization or drop to the bottom line in terms of shareholder value, $38 million. That's nothing to quibble with. And so whether it's the GO Plan or any of our other strategies, I want to impress upon folks that when we save bottom line dollars, SG&A dollars, it drops directly to the bottom line. So there's a case study that you can download on our site for Raven, Alaska. We saved them 50% of their spend, equated to about 1.3 million in savings. So to put that into perspective, their gross margin is 5.51%. So if their gross margin is 5.51% and you do the division, the arithmetic, they would have to sell $23+ million in airline tickets to realize a $1.3 million savings. Now, they're a regional airline. I'm going to say the average ticket price is maybe $200. That's 76,000 tickets that they have to sell. So when you look at that, you have to say, geez, I never thought of it that way. But so if you're an HR professional and you're with us today, you could walk into your boss's office, maybe you report to the CFO, and you could say, hey, I'm going to be your number one salesperson on the entire team. And they're going to say, what the hell are you talking about? See, you're not in sales. Say, oh, yes, I am. And then show them this example, because it's hard to argue with the numbers and the math. And unlike, wellness programs, and they have all these crazy, I call them shiny objects in our business, Scott. Brokers
Yeah.
always walk in with the next greatest thing. And they want you to spend all this money per employee per month with no measurable way, no way to measure the results or the outcome.
Yeah,
The
the soft
beauty,
dollars.
the beauty of the strategy of the GO plan and of what Scott's organization does is you don't have to take our word for it. Every month, you'll get detailed proof that the strategy that we're suggesting is working, because it's going to save the organization money. And so that really is the point. That's what we're here to do. And yeah, if you think that there's no way to control the cost of healthcare, Scott and I are here to tell you that you're wrong. You couldn't be more wrong. This is something that's manageable. We're doing it for millions of people. The largest organizations that are out there, think Walmart, think Amazon, they're not relying on fully insured carriers to save them money. They're rolling up their sleeves and diving in and figuring out ways to save based on everything that Scott and I discussed today.
Yeah, I mean, yes, the amount of money that's in your health plan that should be retained by your organization for you and your employees to support what you're doing is massive. It just is. Again, we do these analysis on a daily basis, and yes, is there change involved here? Of course, you can't accomplish something this significant without some change and taking a different approach, which does mean that, there's a lot of education for members and things like that. But, that's where we know that, again, we've been doing this for 19 years. We know how to help an organization educate members. This isn't something that, we show you an analysis, you sign a contract, and you're kind of on your own. It's not like that at all. There's a lot of hand-holding going on here because we know it's a little bit of a different approach. But at the end of the day, the other tangent value of doing something like this is 100% transparency. The administrators, Ray, myself, the team that would be working with you views your data as your data. We're more than happy to share it with you as much as we possibly can, because without it, together as a team, we can't manage it. So that's another thing that you would automatically enjoy and automatically see a massive change in is, oh my God, I've never had this type of insight into my health plan. Right.
Yeah. And I don't know about you, but I'd be a lot more comfortable spending 10 or $20 million on healthcare as a CEO if I knew that those expenses were being put under a magnifying glass and we were doing everything in our power to ensure that those dollars were being spent appropriately. Right now, if you're fully insured or you're self-funded in an ASO arrangement with an insurance carrier that we talked about, you're really flying blind. You have no clue as to where those savings opportunities are.
You're writing blank checks.
Yeah, why would you want to put yourself in that position? So why don't we turn it over to the audience for questions, if there are any questions. And in the meantime, I'll let you field the questions, Scott. I'm going to just put up a slide for how folks can contact us if they have interest in utilizing our help. And again, folks, if you're not using our help, that's fine. We want you to know that this is something that's manageable, and you should be holding your insurance broker, your consultant, your advisor to a higher standard. Don't just blindly accept whatever comes out of their mouth as Bible. Look for ways to hold them accountable and ask them important questions. Why don't you ask them, hey, what's our PEPY? I heard about this on a webinar, a little fuzzy on the math. How do you do that? And it's simply just taking, again, your total health spend, including your contributions as an employer organization, your employees' contributions, any other money that you're funding in terms of an HSA or an HRA, all in. What's just the healthcare expense? divide that by the number of employees, and that's your per employee per year cost. When you start with that number, it gives you a baseline. And by the way, the national average is creeping up on $17,000 per employee per year. So you know now that if you're spending around that, you're about average. If you're spending more than the national average. And if you're spending less, then you're spending less than the national average. It doesn't mean you're doing a good job or a poor job necessarily, but it gives you a baseline. And I could tell you the average PEPY for our clients is south of $8,000, which is significantly better than the national average.
Yeah, we're getting and sorry about the technology sort of twist that we had today, but we're getting some questions through sort of a different channel. But one question, and I think we'll reiterate it, but could a fully insured group use these solutions? No. Self-funded, if you're in a fully insured situation, the risk is being taken by the carrier completely. Claims are being paid by the carrier completely. So yeah, this isn't something that could work for anyone unless you're self-funded or what we might call level funded, where you are really taking on the risk. Another question. I'm with UMR today. UMR, for people that don't know, is a TPA owned by United Healthcare. Can I use these programs? Yes and no. From a pharmacy perspective, we have clients utilizing our pharmacy solution and are using UMR. On the medical side, the things that we're talking about wouldn't be able to take place. You're unfortunately still in one of those situations where they want to control it, et cetera. Again, they're owned by UHC.
Some of the things that we might be able to do, though, in a situation like that is layer in a concierge so that we're guiding people to high quality care within the system, and also looking at so one of the wisest men that I know in the business gave me a pearl of wisdom that I'll never forget. And to manage healthcare costs, you must do so prospectively, meaning in advance of receiving services, you need to take a look at what the services are going to cost. And we don't expect you to have access or be able to do that on your own, but that's where we come in. And we can curate who the best providers are. And in doing so, we typically also find the lowest cost providers, getting back to that inverse correlation in healthcare of the highest quality almost always being the lowest cost. So in that way, even if you are with the UMR, we can help. It's simply what Scott is saying, though, I agree with completely. Our hands are kind of tied with pulling the trigger and doing some of the other things that we're so good at to reduce costs.
Yeah, and you made a good point about concierge. The other components of these solutions on the pharmacy and medical side involve leveraging technology, smartphone technology and things like that to make things very easy for members and put solutions and decisions right in their hands. Again, give them the ability to be a consumer. That's been that was the whole thing about high deductible plans. Oh, I'm going to dump a bunch of responsibility on Ray and make him a consumer. He's going to be a smart consumer now. Can't be a consumer in healthcare. You can't do it. Call a hospital and ask the question about a knee surgery, then call me, tell me the answer. I'll call the same hospital. I guarantee you we're going to get different responses.
Yeah,
and I guarantee you, once that surgery is done, the estimate that they gave is going to be way low. It's going to come way up here, and they're going to say, oh, there was complications, and it's tough to estimate these things. You just can't do it. If, again, getting out of that traditional environment and being put into a situation like this, now we can. We do have transparency down to that level, and it is as easy as putting it in the hands of somebody's phone. We can take it to that degree. So it's, to Ray's point, this all sounds great. I know that everyone's saying, wow, I'm sure there's some, this is too good to be true type of thinking out there. But we understand that. We hear that every single day. Let's have a subsequent discussion. Let's look at exactly how you are set up and show you exactly what this could do for you and get out of the generalities a little bit. But keep those generalities in mind, because that's where you're going to fall in.
100%. The proof is in the pudding, folks. So we're at the top of the hour. We're going to wrap here, but just know that this is a controllable expense. And to one of our panelists' points, don't accept an insurance broker walking in with a 35% increase and then coming in with flop sweat a few weeks later saying, you know, we had to struggle, but we got it down to a 15% increase or an 8% increase. That is just complete BS. Rely on data, rely on numbers, and we can get that for you. We can put it in front of you so that you can see precisely what the opportunity is. And I think anyone would agree that that strategy is a strategy, and it makes a hell of a lot more sense than just flying blind. So, Scott, I thank you for joining me. And folks, until next time, let's go, baby. Peace.
Have a great day.